You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Joel Klein, the Senior Vice President and Chief Information Officer at the University of Maryland Medical Center. We discuss his journey from the emergency room to the IT department, the impact of low-tech solutions in healthcare, and the importance of empowering clinicians at every level. We also talked about his organization's experience with the recent CrowdStrike outage, what the healthcare industry can learn from airlines, and how he implemented unicorns into his electronic health record. Let's plug in. Dr. Klein, welcome to the pod. How are you today, sir?
I'm great. How are you?
I am doing well. So tell us, just to begin, I like to figure out how you got to where you are. My understanding is that you are still practicing emergency medicine physician, and you're involved in IT. So how does one get from an ER doc to in charge of the IT department at a major medical institution? How does that go?
Yeah, so it was sort of a gradual slide, is the best way to put it. I trained at Hopkins here in Baltimore at the other medical system, and I got hired as the night guy in a very big ER. I think they were seeing 104,000 patients a year in one of our community hospitals, and it was great. You know, the night shift is there's no bosses around, so you have to solve all the problems yourself. It was 7-hour shifts, which I still can't believe we got to do. It was wonderful. Great nurses, great community. And I loved it. And then one day, the phone rang in the ER. I'll never forget this. It was an ophthalmologist in the community, and he was calling to complain about something, and the secretary didn't know what to do. So she called me over. Will you take this call? I'm like, sure. So I don't know what this is, but I'll talk to the guy. So he proceeded to berate me that one of my partners had given out a bottle of tetracaine for a corneal abrasion, which you're not supposed to do, because then you won't blink if like the next speck of dust gets in your eye and you'll get another abrasion, or at least that's what the book says. So he was very upset about this. And so I wrote it all down, and I went into my boss's office, my department chair, and said, you know, this happened. I got this call, and I wrote it down, and I said we would look into it. And he looked back at me and said, so look into it. Go find your partner and talk to him about it. And we kind of stared at each other, and I said, okay. So I did. And that was my first patient complaint, even though it wasn't a patient complaining. And so that started my administrative career. About 2 or 3 years later, I was eventually elected president of the group, with a mandate to fix our incentive compensation, which was very messed up and sort of back of the envelope, squint, and this is how much money we'll give you. So that meant I needed data on all the things that, you measure ER doctors on, like door-to-doc time and throughput and all that stuff, which meant I had to go befriend all of the IT people to get that data. And this is 20 years ago. I ended up with a fair amount of access and very little, guidance on how to get that data, which meant I had to learn the underpinnings and, back end of all of these terrible systems we were using back then. And it was great. All of this was really fun. And it meant I befriended all these IT people. And then came Epic. I was the physician lead for that for our hospital, because when you're a hospital-based doctor, you do whatever the hospital tells you to do. And because they're your master. And that's really where it kind of started. So it grew and grew. I became eventually our CIO in 2019. I worked the first half of COVID clinically, splitting shifts with my old partners. Like I would work 5A to 9A, and then, come have, the rest of my day. And I would say about 3 years ago, it just got to be overwhelming. So as my 15-year-old son says, so yeah, you just go to meetings now. So I stopped practicing around 2-3 years ago.
Yeah, no, it's a good story. And it sounds like you ran towards the things that most of us run away from. Talking with your peers about quality or lack thereof, um, trying to get discrete information so that you can make good management decisions. Those are things that precious few people are interested in doing. So good on you. Now, is this a personality defect of some sort? How would you diagnose this?
Probably. I don't know. I'm a pretty introverted person, and so the thought of how am I going to do X? All right, I'll just sit in my basement and figure it out. I mean, that's a fun day of work for me. Um, I it's funny. I took a computer science class my second semester senior year of college, and I mean, that's when everything was decided and it was kind of irrelevant, but I loved it. And I remember being so angry that I had not done this earlier. I mean, who knows what would have happened? I mean, to be clear, I've had a great ride and I've loved every minute of my career, but you just wonder, it, you know, I guess all of us have aptitude for lots of different things.
Yeah, well, that's fair. Let's get into it. We like to talk about healthcare and human-centered design and kind of thinking intentionally about how we get folks to do the right thing and make it easy to do that. One thing that you've done and that I think you've kind of published about on LinkedIn or in other places is modifying some clinical decision support tools to make them fun. And normally, when people think of what Epic calls best practice advisories or what angry physicians call pop-ups, we don't think of those as fun. They're not associated with anything that we generally like. So, what did you do? How did this kind of how did this progress? Where did it come from? And what kind of feedback did you get when you first started it?
Right. So this started with my wife. We were working together in our kitchen, and she says, "Hey, you got to come see this." So I come over, and they used some sort of task management software or something in her firm. And she goes, "Watch this. I'm going to make up a task, and then I'm going to check off that I completed it." So she does. And this unicorn comes bounding across her screen with a big bright rainbow coming out of its butt. And I just looked staring back at her like, "That's kind of dumb, babe." And she says, "No, it's not. I love it. Look at my unicorn. That's my reward for doing my task." And I just stared at her and she's like, "You don't like it?" And I'm like, so I started thinking about it, and it struck me that if that's all it takes, then I mean, to hell with that. I mean, we can work with that. So I went back to work and said, "Guys, listen, pick something that beats down. Let's start with the nurses. Something that they have to do that they often don't quite get right." I think it was some sort of intake assessment or something. And if they do it completely, then let's give them a picture of a unicorn that says, "You did it great." And I got the same looks like, "What do you want to do that for? That's kind of dumb." And so anyway, we did it, and the nurses loved it, just like my wife did. And so I kind of thought, all right, well, small victory. Next thing I know, my boss, who grew up in finance, he was the CIO at the time, he calls me. I think I was working clinically. And so I was very distracted, but it was him. So I answered, and he gets right to the point and says, "So I understand that you put a unicorn in our multi-million-dollar, professional, thing." And I said, "Yeah, let me tell you, the unicorn, and it's a task and it's great." And the nurse is like, he cuts me off. "So you have 30. I cannot believe you." He was furious with me. He wanted it out within 30 minutes. He was so angry that I had, you know, the frivolity that did not belong in the serious business of medicine. He was not a clinical person. And I thought he was kidding. And it took me another 10 seconds to figure out that he wasn't kidding. So anyway, long story short, we took it out, and I waited, 6 months, but eventually kind of peeled him off the ceiling and got him to see that this was free happiness. This was, easy to do. It didn't cost anything, and it was fun. And so he just kind of glared at me. And so we put the unicorn back, and then we started doing Buddy the Blood Drop and Colin the Colon and all these ridiculous creatures that, had to do with the blood administration and the success of the colectomy prep and just, all the things that we keep trying to get people to do completely. And that led to our system standard around decision support, which is it has to have a picture. It has to have some kind of image. It can be a photograph or a drawing or a doodle, or it doesn't, but it has to be related to whatever it is that we're trying to get people to do. So, for instance, the one that recommends a what's it called? Not hospice, but the folks that manage symptoms at the end of life.
Palliative care.
The palliative care, right? So those folks, right? So there's things that could trigger a consult, and so there's a picture of a patient with some the hands of their family kind of on their shoulder. So some of it is actually very, very serious, but you look right at it and you're like, oh, I know what I'm supposed to do here. And sometimes it gets a little edgy. So during COVID, we when to remind people to get the COVID test for even non-COVID related missions, we had the famous picture of Anthony Fauci, covering his eyes at the famous Bleach press conference. And there were some people that complained that was too political. So we just had a picture of Fauci himself smiling, although I thought the first one was pretty funny. But yeah, we think that has been a small victory here of really trying to we don't want people to read a paragraph of what we're looking for them to do. We want them to just glance at it and immediately react and say, "Yep, got it." And so that's what it does.
Well, it saves time, but I that quote, and by the way, I'm going to write a book now called Free Happiness.
That's right. One smile a day. If we can do one smile a day, if you round in any hospital and go down to the ER, is a great place to do it, especially during COVID. Yes, it's an amazing profession, amazing job. You're really making, you're denting the universe down there, but it's really hard. And, you walk around with a basket of chocolate, that works too. But if you get, this unicorn with a big sign that says, yay, yay, Joel, or yay, Craig, hey, that's, free happiness.
Yeah, I love it. And so I think you're getting multiple benefits, right? You're getting that free happiness, that kind of maybe that little jolt of an endorphin that, oh yeah, there's really this is not just checking a box for the sake of checking a box. But you're also, to your point, hey, if I see a picture of Fauci, I know what I'm supposed to do. Like I don't have to read any of that text. And so it's actually going to make it this task faster because I can very quickly identify it.
And Epic does something similar by allowing you to customize your workspace. So there's those famous, pictures where the cow getting beamed into the UFO, or all these they're cutesy little ways that you can decorate your background. But the safety feature is that you don't walk up to somebody else's workstation and you don't accidentally use another person's login. So there really is a practical purpose behind just look at that ridiculous cow.
Yeah. And certainly there was a lot of pushback, I remember, from CIOs like yourself, actually, when some of that personalization was being introduced, saying that, well, it's harder now for us to support because when a user calls in and says they're stuck at this one area, it might look a little different for nurse A than nurse B. And that makes the help desk people a little bit more nervous. But clearly the benefit's worth it.
Yeah, well, so I will admit it's possible that our, entry-level employee, I didn't get Buddy the Blood Drop. Like, what does that mean? What team does that go to? I suppose. But I think it has more to do with culture and acceptance and, what do you mean smiling? There can't be any smiling here. We've tried to do other visual things. So when you log into most of our applications in our organization, you get the splash screen is art from our employees. So we have employees either paint something or take a picture of something. It could be, a photo of sculptures they've done. It could be, During cherry blossom season, we had an amazing picture down, since we're so close to DC of the cherry blossoms. And it's cool. And we acknowledge, we put their name on the work of art. And it's another way for us to recognize employees. And it also, again, I know I'm in the right application because that's the one with the cherry blossoms.
Well, you were mentioning rounding. You were saying that, if you ever go rounding, and that's where apparently people take care of other people. This is what we're talking about. I seem to recall that. That's part of what happens at hospitals and doctors' offices. So you've written about a rounding party where you take a bunch of clinical and non-clinical folks and walk around. So tell me, how does that work, and what are the things what do you learn, and how do you get some of these administrators who, like you, are maybe not super excited about meeting new people and going to strange places. And by strange places, I clearly mean the emergency room and the PACU.
Yeah, those are strange places, but they're amazing places. So we had this problem. I'm sure a lot of us in healthcare IT have, which is you're live on whatever platform you're talking about, but let's call it your EMR. And time passes, and now how do we continue helping? How do we have continuous improvement in our users' ability to understand the system, use the system, and how do we keep meaningful feedback coming? Obviously there's people who are going to pick up the phone and call the help desk and complain about something, but there's a lot of stuff that you get from just talking to users. And so we have an informatics team, like a lot of places, and they would kind of go around, and through Brownian motion, maybe they would encounter another employee working clinically who wasn't too busy, who could actually offer some feedback or be receptive to some training. And basically the yield was pretty low. And we struggled with this for a long time. And finally, our informatics team said, you know what? Why don't we just posse up? We'll get like a massive, bolus of informaticists, and we'll have them round en masse, in force, as like a squadron. And we'll divide them up, and we'll send them to, blanket a department for some period of time. And so there'll be 30, 40 of these guys. They'll all go to one hospital. They'll all meet in the cafeteria or something, and they'll have assignments, and they'll go out, to areas where they specialize to try to get this, feedback. What's working, what's not working. Let's gather the staff up and let's talk about it for a minute and have it be an event. And thus was born the rounding party. And they've been unbelievably successful at both, again, trying to do a bit of training, but also getting feedback, constructive feedback that we never would have gotten any other way, because a lot of these staff are people that don't, really want to get involved in IT governance or go to meetings, stuff like that. So it's been very, very helpful. And now what we do is we will rope in non-IT leaders at that hospital who hear we're coming and they want in on it. And so they'll come around with us, and it gives them insight into how their teams are using the tools. And it's great for them because they get to see us trying to help, as well as, hearing firsthand the challenges that their own teams are having.
So it's a great idea. And it's similar to kind of I've seen some other hospitals do this SWAT concept where, they'll go into a clinic or a particular department, but they'll do it for 5 days. On day one, they're watching. Days 2 through 3 or 2, 3, and 4, they're doing some training, but also doing build, fixing things that are easily fixed, so that they can show progress by Friday, where they do a debrief and kind of get out of town.
Yeah, no, I love that. Actually, the thing you have to be careful about is lighting off projects with these things inadvertently. So you have to keep scope to a minimum. Because sometimes we'll say, well, could we just interface Epic to this toaster over here? And you have to be careful not to. So you have to have a little bit of ground rules around that. But I mean, the idea of a multi-day rounding party, that's great.
Yeah, I think at one place I saw them, they kind of broke the needs into 3 different buckets, and I think probably everyone through governance has, these big boulders or little rocks or whatever they call them. And so there was hey, these are things we can fix by Friday. These are things that are a little bit bigger, but we could probably get them done in the next 4 to 6 months. And then there's these big projects like integrating with the toaster that certainly can be done, but we're going to have to figure out where that goes with the priorities. And as long as you, like you said, as long as you set expectations that, hey, we're not here to fix everything, because some things are not broken and some things take a lot of money and time, and we can't just snap our fingers and make that happen. People understand that. In my experience, often it's the little tiny things that can literally be fixed in 10 minutes that people are most appreciative of. It's that documentation template that has a typo in the second paragraph with the third sentence that has 2 periods at the end. And it makes me crazy because I'm an anal retentive physician or nurse and I have to fix that every single time. And boy, if you just fix that, I don't really care about the new cardiology module. Like that, that's not as helpful to me in my mind as you fixing these little tiny things. So
yeah, I think the other thing that we have to think through is how do we do this in the ambulatory space, right? So we have a ton of, practices that are not physically co-located in our hospitals. And this solution doesn't exactly scale to those environments. Now you can scale it down and, send 3 people to one place, but it's not quite as geographically, easy to do that. But that's, I think, another thing we're thinking about.
Yeah, I think that sounds fair. One of the things that I think you saw, and maybe this was during when you were rounding, was that an inventory management system that you thought was ingenious, the 2-bin system.
Oh yeah.
And so I'd love just to kind of talk about that for just a few minutes. It seems very, very low tech. And I know I'm talking to a CIO now, but how does this low tech system work, and how can it go? How can it work, and how can it break down?
Yeah, so this is just about the dumbest, most ingenious thing in the world. I don't understand why this isn't, So the idea is you're in the clean utility rooms of every, clinical area in the building. Let's say you need, I don't know, some gauze. So you go into this room and you find the gauze, and there's a bin and there's some gauze in the bin. But behind that bin, there's another bin with the same thing, more gauze. So what you do is you take from the front bin, and people come throughout the day, they take gauze out of the bin, and then there comes the point where the bin is empty. And what you do then, you train everybody, what you do is you take the empty bin and you throw it on top of the rack of the shelving. And there's a bunch of other empty bins up there. And then you take the second bin, the one that's been hiding in the back, and you pull it forward, and then you get your gauze from that bin and you go about your day. Then the supply chain dude or dudette or people, they show up and throughout the day, and they pick up all of the empty bins that are now up on top of this shelving, and they take them downstairs and they restock them, and then they bring them back up and they become the behind bin. And so the reason this is genius is it's so low tech, it's perfect. It forces product rotation. So you're not like constantly taking from the front and then having this stuff expire and you have to throw it out. And it's a great way of just managing your inventory of stuff. Now, there's a few things you can't do this for. So, huge bulky things, it's obviously, less practical. There are some clean supply rooms that I have seen that are so packed full that, it's already a fire hazard and you can't really, do that. But, think about all these projects that you've heard of weighted bins and, that are connected via wires to some Pyxis like, crazy system where, the weight of the gauze gets, measured or some nonsense like that. Or even worse, we're going to charge individual items to now we don't do, patient level charging like that here. I know in some places, you have to. But just from how do you keep the place stocked? It just was such a great, and so we're actually doing a project. We're calling it the California Closet Project for your stuff. And so we're literally sweeping through our whole organization, 2-binning the whole place. And the other interesting thing that you get to do is there are things in your clean supply closets that, I'm sorry, you just don't need them. You think you need them, but that's like the extra, workout gear that you bring on your vacation. You're not going to use that. And so if you have somebody who's actually doing some, even minimal time and motion study and, really looking at what's being used, you can free up space. You really can. And you have to be careful because it's someone's closet and you're, moving their socks and whatever. It's not yours. It's not your home. And you have to be respectful and you have to have good governance around that. But you can make space and it can look like one of those, makeover type situations. And so it's a great product, not only tangentially related to IT. I mean, obviously the ERP aspect of this does come into play a little bit, but it's a great project.
Yeah, I'm most disturbed, and I feel like you see me when you are telling me not to bring that extra workout outfit on vacation.
No judgment. No judgment.
I know, but I do feel judged despite that. All right, let's move on and let's talk about flying. Now, you're not a pilot, are you? But
I wish that I could be a pilot. I absolutely love flying, but I am deathly afraid of heights, which is strange.
That is strange. All right. And so that's the problem with you becoming a pilot, is that they generally fly in the air.
True. That does seem to be the way. My wife got me a flying lesson for my birthday, and so I went in the little plane and got up there. The little plane didn't bother me. That's all fine. I am comfortable that it is a real airplane. And the teacher says, "Okay, fly the plane." So I'm flying the plane. He's like, "Okay, turn." So I bank the plane, and the plane tilts, and I look down. And I just thought that that's it. I'm done. Because, at some point you have to solo pretty, after maybe 30 hours, you're up there flying by yourself. You have to do that. And I just realized in that moment, there is no way I could get over my don't look down. Like, nope, not doing it. But I do love like commercial flying. Absolutely love it.
Well, I asked the question because you've written a lot on LinkedIn and other places about things associated with aviation, and so one that you relate to healthcare, which I love, and one of those was talking about the authority gradient, and this concept that is very, I guess, well established and respected in the cockpit, but not so much in healthcare. So what is the authority gradient in aviation, and how is it related to healthcare?
Yeah, so I think all of us who have spent time in the clinical space recognize this phenomenon. And it's, people have ranks in hospitals, right? I mean, within doctors, there are, medical students and interns and residents and fellows and attendings. And it's there's a pecking order, and then you layer in all the other staff, and they're all part of the team. And but the breakdown happens when that team becomes communicatively dysfunctional. So, in other words, when people stop having the sense of safety that they can say something that they're seeing. So when a nurse kind of comes up to the doctor and you see they are really scared they're going to get their head taken off by asking their question or reporting something that the doctor is going to find insignificant, but the nurse doesn't know that, right? That's how bad things happen when we don't deal with that. And so what's in aviation, they've really come to have a really structured way of talking about this in a cockpit situation. So you've got far fewer people, obviously, so it's a less complex environment. But you'll have, a captain with, say, 20,000 hours and a first officer who might have, say, 700 hours. And so that's a really high experience gradient, which will translate to an authority gradient. And there have been so many accidents where that first officer is watching the captain do something really stupid, and is afraid to say something. And so the way a lot of airlines do it as part of what they call crew resource management and are trained to do this is that the first flight of a day of a team working together, they will brief, what do we see, as our threats, to today's operation. And it's the responsibility of both crew to say, well, we do have a big authority gradient today. So as your captain, I'm going to remember that I need to put that aside and make sure I'm asking you what you think throughout the day. And the co-pilot will say, and I will remember that I too am a member of the crew, and I'm going to remember to speak up, even if I think, even if I'm concerned that my point might be trivial or if I might be wrong. I'm going to make sure that I say something. So they have that explicit conversation. I don't think I've ever been in an operating room where anybody talked like that. Certainly, I've never been in an ER where anybody talked like that. And that's what's missing. And, culturally, we got to deal with that. And we're a long way from that. It happens in IT where you have a junior analyst who is afraid to tell me something or afraid to tell their boss something because it's the scary boss. And that's how things happen. So it's something it's probably applicable to any work environment, but certainly one where safety and one wrong move and there's a big impact come into play.
Yeah it's a big deal. I never really thought about it. You're right, there's a pecking order that's so obvious to physicians. It's at the bottom is medical students, actually third year medical students, and at the top is the attending, and even attendings have pecking orders. And
right. I mean, think about when the dean shows up to do his 1 week, of actually practicing. Think anybody's going to tell him, sir, I think you overlooked, you can, but, it's a lot harder to do that. And again, it's being explicit. It's routine that we're going to acknowledge this risk, acknowledge this threat. It's part of our job too. And that takes all the mystery and all the apprehension out of it. And it's just part of what we do here.
Yeah, well, it's the word that I keep coming back to is intentionality. You're intentionally bringing this up, and like you said, both the senior person and the junior person, and the senior person acknowledging, yeah, boy, I do have a lot more experience than you do, and it might have been different yesterday, where they might have been much closer. In which case, that authority gradient is not as dangerous. And boy, yeah, not saying things can be very bad for everyone involved, from the doctor to the nurse to the patient. That's for sure.
Or even from IT, even from the clinical space to IT. So, we'll have a new, last night was our quarterly upgrade here, our Epic quarterly upgrade. I'm sure there's something, broken. And so if a clinician's like, well, I'm not going to report it because who cares? Or I'm not going to report it because what do I know? Well, we can't fix it.
Yeah. And I think a lot of that is also that, acknowledging it is kind of adding transparency to it, to say, yeah, I understand you might be scared. And if you say something, I'm not going to belittle you. At least I hope, I hope that's the case. I once, I wrote about this in my book. I took my daughter to the child neurology clinic at the university center where I used to live, because she was getting headaches all the time, and of course I was concerned. And they had just installed Epic at this place, and so I'm watching the nurse who's rooming my daughter, and she goes to the reason for visit section, and she types in other, because you have to choose there's a list of things. She types in other, and then she has a free text box right next to it, and she types in the word headache. And I watch her do this, and my daughter's pleading with me to not say anything, of course.
But you can't help yourself.
I cannot help myself.
I have the same
Dr.
reaction.
Klein.
I cannot believe they put other when headache is in the list.
Well, no, headache was not in the list.
It's
right?
not in the category list. That's terrible.
It was not in the category list. Now we're talking, on the inside here, category list. It was not in the category list. So I said to the nurse, I'm like, I just have a question. Do you see a lot of kids with headaches here in the child neurology clinic? And I already knew the answer to that question. She said, well, yes, we do. And I said, but I noticed that you didn't have a selected choice. There was no headache there. You had to actually select other and then type it in. And she goes, yeah. And I said, did you tell anyone about this? And she said, no, I just do this. Right. And so we have to make it kind of, again, I don't, maybe that's a little bit of the authority gradient. Maybe that's a little bit of, well, I did tell someone once about something and I submitted a ticket and that was it. I never heard about it and never got fixed. And so after that happens once or twice, or my friends tell me about that, it's done. I'm not going to tell you that anymore. And so, and that's information that, boy, again, an easy fix, and it makes you look a lot better. Cool. All right. Well, let's see. Moving on. Recently, and I think you're aware of this, there was a third party called CrowdStrike that makes some cyber protection technology. You've heard of them?
I have heard of them.
Yes, and I believe you're a customer of theirs.
That's possible.
And you've written about your experience when they had a little bit of a technical snafu, and you related it to how to know that you have the right partner. And so, can you kind of tell us, hey, what happened, and how did it work out, and did you have a right partner, and how do you make sure that how do you judge that, and then how do you apply that to future partners?
So that was such an interesting incident for us, as it was, I know, for lots of organizations, healthcare and not healthcare. But I think to really get at your question, we ended up on the phone with our CrowdStrike person within, I would say, 30 minutes of that incident starting. So at 2 a.m. Eastern time, they actually got on the phone with us after we had, suddenly figured out what the problem was. And later in the day, there were probably 7 or 8 third-party systems that were just as affected as we were by CrowdStrike, where, they were down and they weren't going to come back, anytime soon. And in contrast to CrowdStrike's, communicativity with us, they got on the phone with us and told us what to do. These guys wouldn't even answer all these other vendors, where they just wouldn't answer the phone. They pointed us to their website where they're going to post updates. And the update is, we will let you know when we have an update. Just no stonewalling, nothing. And, just compare those two reactions. Now, I will be clear, what CrowdStrike did was not good. And they have, I think, started to disclose a little of how what happened, and that's good too. But I will just tell you, as somebody in my role, it matters a great deal when I know I can get somebody on the phone, where I know somebody will be straight with me about what happened, and I don't have to sit around and wonder, how am I going to get out of this? We've had a couple of third-party issues, in the last few years. And it's just so interesting to see the difference in how organizations handle things. I mean, the whole topic of how you communicate during a cyber incident is really complicated. And, you get into, you can't say too much, and, the discoverability of what you're saying and so forth. But I will just tell you, in the heat of the moment, it makes a big, big difference to me. And that was one of the things that stood out to me in that whole incident.
And then, so how do you bring that lesson back to your entire IT department? Because they're also kind of sometimes delivering answers to their clinical or operational counterparts.
Yeah. So absolutely. And the lesson is, get up there and own it. So I have stood up many times in front of our, CEOs, CFOs, even, board meetings. And, when we made a mistake, or when something happened that we could have stopped, or it doesn't matter. Just get up there and own it and deal with it. And because it's not going to go away. And when you start bobbing and weaving and making up the best is when people start using the passive voice. Like, an error was introduced into the system. Like, it just rained out of the sky and we don't know where it came from. Don't do that. I mean, you can say, we have an analyst. This is what they did. This is what they were thinking when they did it. And obviously we've spoken with them, but this is what happened. And, you in healthcare, there's this whole legacy of blame. I mean, that's the whole M&M story, when you get up and, this parade of horribles. I mean, it was intended, I think, to be, how do we make a teachable moment out of, a terrible situation. But I think for the organization that's dealing with that situation, the other part of it that gets lost is we made a mistake. And I know families, they respond very differently when you do that. When you say, okay, this is what happened. There's a whole, conversation around, an I'm sorry program in the malpractice space, where you acknowledge something and apologize for it that day instead of, letting something, so there's so many ways this applies. We saw it in how the airlines, reacted, to this crisis, and the different responses. So I have tried to lead by just be honest. Don't, go too far, but say what happened in plain English and own it.
Love it. Well, this was a great conversation. I really enjoyed it. We love to end our talks by asking the same question, which is there anything that's so well designed in your life that it brings you joy and happiness every time you use it? And sometimes people talk about technology and sometimes they don't. So are there one or two things that are so well designed you love them?
The first thing that comes to mind, and it's going to sound like I'm some kind of violent person, but I'm not. I have a 10-inch Henkel's chef's knife that I have had for a very, very long time. It is, I think it's a Twin Star. I don't know if they make them anymore. It's a German knife, and when I bought it, you could either get the one that has the 2 rivets or the smooth handle. And if you were a serious chef, you got the rivets because that was like the classic way. But the one I have, it's a very smooth, flowy handle. And when I hold that thing, I mean, it's going to sound corny to say it's like an extension of my hand, because obviously it's a knife and not an extension of my hand, but it just feels great. And if I go and sharpen it on my sharpening gadget, you can just go to town with that thing, and it just feels great, and your hand doesn't get tired from holding it all day. I had a job as a prep cook in a fancy restaurant when I was in med school.
Wow.
And yeah, there's pictures of me making mashed potatoes in a chef outfit that are pretty funny out there somewhere. But you have to chop vegetables for an hour or 2 or 3, and having a good knife, it makes all the difference. So that's my answer, and my chef's knife.
Well, that is exciting. I have to say, I would not have predicted that. What I was going to predict based on your writings was a cherry pitter.
Oh, the cherry pitter. Yes. So every summer when it's cherry season, you it's cherry season because the price of the cherries goes from like $6.99 a pound to $4.99 a pound. Then there's like a week where they're $2.99 a pound, and you just should buy all the cherries you can. But then you have to pit them. I mean, I guess you could just eat them, but that's not as satisfying. So everyone has their little OXO stupid little cherry pitter where the little, spiky thing breaks, after 5 pounds of cherries. I found this German, just luxury $30 item on Amazon, and you can literally stamp out the pits of a pound of cherries in 5 minutes flat with this thing. And it is just fantastic. I just put it away for the season. It is a fantastic device. That is true. That's a toss up between that and the knife.
All right, fair enough. Yeah, you put a picture on LinkedIn, and we'll try to put a link in the show notes of you next to this machine. And I don't know. I know there are some kitchen gurus who don't like devices that do one thing, but boy, when you find one that does just this thing and it does it better than everything else.
So Alton Brown is wrong about that.
Oh, yeah, you got the reference. It's perfectly fine to have a single use item.
you don't want a giant library of them because you'll run out of room in your drawer. But, for something that truly meets the need and an important need, get the right tool.
Awesome. Well, Dr. Joel Klein, it has been a pleasure. Thank you so much. I really appreciated your time and look forward to more of your LinkedIn posts.
I'll keep them coming. Thanks so much, guys.
Thanks for tuning in. We hope you enjoyed today's episode. To learn more about Joel, follow him on LinkedIn by searching for Joel Klein, MD. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.